Welcome, everyone. I'm thrilled to explore the art and science of dermoscopy with you. This is our introduction to the dermatoscope, Dermlite DL200 Hybrid, and we'll be using it to examine the skin and nails. Let's play detective together. Our agenda for today is to understand the anatomy of Dermlite DL200 Hybrid, and then the functions and physiology of the dermatoscope so we can decode histology without using a knife. We will learn about the polarized and non-polarized modes, as well as the contact and non-contact examination. We will move on to review the hygiene and the appropriate choice for an interface medium when examining the skin and mucosal surface. I will review the interesting sign that allows us to be confident and clear about diagnosing some common benign and malignant conditions of the skin. Finally, we will move on to the examination of the nail with the dermatoscope. ONYCHOSCOPY is a interesting and developing field, and now we have the ability to discern common malignant and benign conditions of the nail, as well as infectious and inflammatory conditions with the use of this dermatoscope. Dermlite DL200 Hybrid is a handy little scope with a metal body, which is easy to clean, but it can be slippery, so keep it protected in the silicone sheath that it comes in. As we look at it, the circular lens assembly with the black focus ring around it is seen easily. Just to the left of it is the power button, and to the right of it is the button that allows us to switch between polarized and non-polarized mode. Looking at the undersurface of the dermatoscope, we see the light source, which is made up of 21 LEDs, out of which 15 are polarized. We also see the contact plate and the power source under the thumb.
Now that we know the anatomy of the DL200 hybrid scope, let's see its handling. Physiologically, it's designed to be ergonomic and fits nicely in my palm. We turn it on with the thumb. The power source turns on and you can see the battery level with the three lights just below the lens assembly. The index finger goes over the mode button to turn it from polarized to non-polarized mode. This light just to the right of the eyepiece is turned on when the dermatoscope is in the polarized mode. As we turn the dermatoscope, we can see the lens, the contact plate, as well as the light source. The LED lights make up the light source, and the dial around the eyepiece, when we turn it counterclockwise, extends the faceplate, which also has a 10 millimeter reticle to measure the lesions. And we bring it back up to do examination in the non-contact mode. And the power button, again, we can turn it off when the examination is done by pressing on the thumb.
Using appropriate interface medium is important to see the surface layers. We recognize that alcohol is a commonly used interface medium for skin, but ultrasound gel makes a better contact medium for curved surfaces and irregularities of the nail unit. Hygiene measures are practiced using either the ice caps or saran wrap. As an inexpensive substitute for the ice caps, saran wrap is easily available and can be used either directly on the skin or lips or on the dermatoscope. ensuring that there are no wrinkles or crinkles between that would impair the view. Now that we know the anatomy and handling of the scope, let's learn about how to examine a lesion with this. Hold the dermatoscope about an inch from the area to be examined. Bring your eye 1 to 2 inches from the eyepiece. Adjust the distance and bring the image into clear focus. Using the ring, middle, or pinky finger helps to make the camera stable just like a tripod. As we look at the skin, you will remember from the pre-learning modules that polarized light allows us to see 100 microns deeper by removing the glare. It also helps us discern collagen, blood vessels, and other structures well. With non-polarized dermoscopy, we look at structures from the top to the dermoepidermal structure. So we're able to see scabies, milia-like cysts, and surface veil of a melanoma quite well. To be able to see the details and diagnose certain conditions with certainty, we need to do contact dermoscopy. For this, we need to extend the faceplate, apply the interface medium on the skin, and practice appropriate infection control while we look through the eyepiece. Once you toggle between polarized and non-polarized mode, as we will see in the next slide, we will be able to see a dermoscopic appearance of a seborrheic keratosis with milia-like cysts being seen very clearly.
Hold on 1 second. Yeah,
Yeah,
it's good.
it's good.
This is
This is polarized light.
You
You can see
the
the
collagen
collagen
bundles,
bundles.
and they
They
disappear
disappear
with
with
non-polarized light.
non-polarized light.
It's a classic,
Classic
blink sign,
blink sign,
and that
and that
confirms
confirms
likelihood of
likelihood of
BCC.
BCC. Okay, perfect. Blink sign with collagen bundles showing up clearly and disappearing with non-polarized light can also be a feature of amelanotic melanoma. Looking closely at the nails, we will be able to discern benign, malignant, infectious, traumatic, and even inflammatory nail conditions non-invasively. This can help us detect clues for systemic diseases like connective tissue disease, psoriasis, even alopecia areata. Essential piece of onychoscopy is recognizing the various structures that make up the nail unit. It is essentially made up of the nail plate, which is the dead keratin on the surface of the nail bed, which is the vascular structure underneath, the nail matrix, which is proximally often seen as lunula, which is the distal edge of the nail matrix, and the proximal nail matrix is often hidden underneath the proximal nail fold. Looking at the distal edge of the nail is important because the free edge of the nail, as well as hyponychium, can provide important clues to disease. Another important principle in the examination of nails is to examine all 20 nails as much as possible because irregularity of pigment or changes on multiple nails can signal certain inflammatory conditions as opposed to only one nail involvement. Begin onychoscopy after we have looked at all 20 nails and focused on the abnormal nail by first examining it using non-contact dermoscopy because it allows us to see the surface scale and pits like in psoriasis. Once we have looked at the nail with non-polarized, non-contact dermoscopy, we will look at it with the polarized lens to look at the deeper structures and move the dermatoscope back and forth and front and back to look at the entire nail unit. Applying the gel to facilitate contact examination begins with non-polarized dermoscopy and polarized dermoscopy for colors, hues, vessels, and pigment. In the end, ensure that tangential dermoscopy of the distal free edge of the nail as well as the skin underneath the nail, the hyponychium, is done. Common nail tumors like digital mucoid cysts, which often put pressure on the nail, can be easily seen with transillumination, as is glomus tumor. As we reviewed earlier, the best interface medium for the nail is ultrasound gel, requiring wiping it off at the end and then washing off the contact plate with water before cleansing it with alcohol. Here's a classic dermatoscopic exam of the nail, and actually visual exam of the nail plate showing pits of various sizes as well as distal onycholysis. Just like a detective, we are looking for abnormalities of color, shape, thickness, and bands of different colors, as well as separation or damage to the nail plate. Onychoscopy was first used to examine linear pigmentation of the nail, which can often be a concern for melanoma of the nail. Before we examine a pigmented nail band, it's important to recognize that there are certain clinical clues, even before dermoscopic examination, that would suggest a high probability of it being melanoma. So the top 5 are the pigment band being wider than 6 millimeters, triangular shape of the band with the wide end closer to the nail matrix, a positive Hutchinson sign, which is pigmentation of the proximal nail fold, or the hyponychium, or the distal skin underneath the nail edge. The fourth feature that helps narrow in on the concern for melanoma of the nail is involvement of only one digit and onset in older adulthood. Finally, if there is dystrophy of the nail along with pigmentation, then suspicion for melanoma would be high. This is a classic triangulation of the pigment band on the nail with the wide base of the triangle toward the nail matrix. This is worrisome for melanoma. Remember the triangle sign. If the base of the triangle abuts on the nail matrix, it is worrisome for melanoma. If the base of the triangle is towards the free edge, it may be other conditions like trauma or fungal melanonychia. This is dermoscopy of the nail unit with irregular bands of pigmentation that are gray, light, and dark brown. Bleeding under the nail can present as a longitudinal band, but subungual hemorrhage often presents as distal linear filamentous pattern. Fungal nail infection presents as cloudy, yellow, white, or multicolor streaks with their wide base more distal. Jagged proximal edge with spikes. Some people call it the aurora borealis pattern. Dermoscopy of the proximal nail fold to determine the number and large diameter of the capillary loops can give us a clue to the diagnosis of systemic conditions like systemic sclerosis. Evaluating the linear band of pigment or white or red or hemorrhages and seeing the origin of the band can determine the origin site of the lesion. So this linear band is originating in distal matrix, which is the lunula. Squamous cell carcinoma or onychopapilloma of the nail can present as a triangular distal area of nail separation with a subungual plug and hemorrhage. Onychomatricoma is a common nail condition where the nail plate is thickened with a white band and it has honeycomb pattern distally. This is a nail with pigmentation of the eponychium or cuticle, which is only visible by dermoscopy, making it a micro-Hutchinson sign. This is just a reminder to examine the free edge of the nail and the hyponychium. This is my ring finger after I developed some nail bed separation when playing the ukulele with gusto. As you begin your journey with the dermatoscope, I hope you will pay attention to much more skin and many more nail conditions and start recognizing patterns that help non-invasively identify malignant and benign nail conditions as well as infections and inflammation and connect the dots to identify patients with systemic sclerosis and conditions like psoriatic arthritis. Thank you all for delving in today and diving deep to find focus and flair and learn to see beneath the glare. You're ready to notice, name, and nail it.